Before we start, any apologies? I received apologies from Councillor Charlie Smith because he's doing a council surgery that I should be doing. Have we got any other apologies? Helen Dennis, she's still on maternity leave. We're expecting Councillor John Hartley as her replacement. And apologies for lateness, Councillor David Noakes as well. Any apologies? No. Okay. Any urgent business? We haven't got any urgent business, you'd be pleased to know. Any declaration, disclosures, any? I think it would only be David, isn't it? I think David, in terms of his role. Oh. I think the only declaration, health and well-being, it will be Councillor David Noakes because of his links with, I think it's Richmond, and his health, his links with health.
Yeah, I think occasionally he mentions his membership of health and well-being, but I don't know, he hasn't done that recently, and I don't know if he's still a member on that. But
okay.
Yeah. I'll check.
Just note that anyway. Okay. Okay. Quickly do Kevin thing. Quickly do introductions. I'm Councillor Victoria Lisa, the chair of this commission in Goose Green Ward. Am I right?
Councillor Paul Dunning, I'm also a member of the committee. I'm dealing with a slight crisis at work, so just so people know, if I run out, it's an entirely unavoidable reason. It's not a horror at something that you've said. I will be coming back, but I'm really, really sorry. It might require me to take a phone call.
Commission, even.
Can I just remind people to like the press center?
Okay, if members can look, and can we just check point 4 if everyone's got the minutes from the last meeting, the 21st of January? Just apologise, I know that minutes have been passed out late and that's been due to illness and short staff, but hopefully everyone's had a chance to have a look at the minutes of the 21st of January and any outstanding business will be picked up in today's meeting. And the 2nd of December as well, apologies for that as well. So if there's any outstanding issues, we've tried to carry it forward to this meeting. If we go to point, they agreed as an accurate reflection of people who were there, because I know through illness and different people have been there. Agreed? Agreed? Okay, agreed, thank you. If we move swiftly on to point 5, community pharmacies and substance misuse services. Thank you.
So good evening, everyone. Thank you very much for. Sorry, Chair.
If you just introduce yourself, thank you.
Right. So I'm Kevin Fenton. I'm the Director of Public Health and the Strategic Director of Place and Wellbeing in Southwark Council.
And I'm Farhat. I'm Consultant Public Health here at Southwark.
And I think what would be helpful, Kevin, if you just give an outline, not for the briefing, because I know we had a briefing a couple of weeks ago, phone, but just outline of where we are in terms of the community pharmacies and substance services. There were some concerns from some members about how that's been rolled out, how some of the funding been cut, and what's the impact, potential impact on some of our vulnerable service users, especially in the north of the borough. So if you could just probably give us a quick snapshot of the situation. Thank you.
Wonderful. Thank you very much. And again, thank you for inviting us to present this evening. I'm going to do just a brief overview to provide a bit of context to the decisions that we're making in managing the public health grant and the importance of really looking at our data and how our funds are being spent to maximise health impact. And my colleague Farah will go into the issue of the community pharmacies in a bit more detail. So the context for what we've been trying to achieve with our alcohol and drug spend in the borough is maximising input in the context of a declining public health grant and a public health budget. And as you may be aware, over the past 5 years, we've had a year-on-year decrease in the allocation for public health in local government from central government. So we've had to manage within the context of a ring-fence grant, which has been declining. This has meant that we've been having to make tough decisions across our portfolio. As you're aware, the public health grant funds not just alcohol and drug services, but children, young people's well-being services, sexual health services, a range of mental health and well-being activities within the borough, in addition to alcohol and drugs. The decision that we're going to be discussing today is work that we've been doing over the past 3 years in terms of reducing, having to manage the reducing budget on alcohol and drugs, but also thinking of how we both align our expenditure to be consistent with expenditure for other boroughs in South East London and across London, so ensuring that we're benchmarking our investments so that they're in line with boroughs in London. But also, while we're benchmarking and aligning that funding to ensure that we're working towards better outcomes. So as you hear the summary from Farah on our specific funding for community pharmacies, the context has been declining resources for public health, our work to improve health impact, and our work to work with our partners to help us to manage the budget effectively. So with that, I'm going to hand over to Farah, who will provide a little bit more detail on the journey that we've been on with community pharmacies and the provision of alcohol and drug treatment services.
Thank you, Ken. So this is around pharmacy services for drug and alcohol, and this is basically there are two services we're talking about here. One of them is around supervised consumption, so as you would know, it's sort of methadone consumption that you get in pharmacies. The other is around needle exchange, so swapping dirty needles for clean needle kits and injecting kits. And both of them are really effective at reducing harm in these quite high risk groups. So we have a contract across the borough, and pharmacy providers can opt in or opt out as they want. There's no obligation to take part. It's very much up to them. It's up to them as a sort of economic decision whether they want to participate. And it's been running since the 1st of April 2017, and it's going to end at the end of this financial year. And they can opt in to do either the needle exchange, or they can do the methadone, or they can do both. It's up to them. They're not tied to doing both or one or either. It's completely up to them. So we were coming up to the end of the contract, and we did a benchmarking exercise across our neighbouring boroughs and other boroughs in London to see how much we were spending compared to our neighbours, and we realised that we were spending twice as much as Lewisham, our neighbouring borough. Per methadone, this is for methadone dispense, we're paying twice as much per methadone dispense. And so we thought, actually, if Lewisham have been paying this for the last 3 or 4 years, and they've still got sustainable service, then what's the difference between our pharmacies and their pharmacies? Why can't we ask for the same lower price? On the needle exchange, it's a slightly more complex picture. We were paying pharmacies a retainer every year just to take part in the service, and then we'd give them money on top for giving out the kits. But when we looked at that activity, we saw that some pharmacies were getting the majority of their money from the retainer, and they weren't actually giving out that many kits at all. So you know, it was basically, they weren't really being incentivised to do any more distribution or reach out to any more vulnerable people in the area. So with that in mind, we thought actually maybe we should change the way we do those payments, and just have it a sort of a fixed fee per item basis. So the more items you give out, the more money you get, and if you don't give out any, you don't get any retainer. So we thought that would be a lot fairer. And we're not on that. We're not reducing the total amount of money we're giving out. So the people who are still doing lots of activity will get the same amount or more, but the people who are doing less will get less because they're not getting their money from the retainer. So we wrote to the LPC initially, the local pharmaceutical community, to tell them that we were going to be changing our tariffs. They expressed disappointment that we were reducing the money, but we felt that it was something we had to do because of our neighbouring boroughs having the same price and us paying double. After that, we informed the pharmacies. We wrote to them via Farm Outcomes, which is a tool we use to communicate with them. And they check it all the time. It's a recording device they use for tracking invoicing and payment, so it's a good communications medium, and you know they're going to get it rather than just sending a letter in the post. And we asked them to come back and tell us if they wanted to participate in the scheme based on this new tariff. So when we wrote to them, for the price reduction in substitute prescribing, 15 out of 18 said that they would be happy with the new tariff, and for the injecting, the needle exchange, 10 out of 14 agreed that they would want to participate. And then we also had some providers who were in talks with us saying that if any of those a few of them came back saying they weren't sure if they wanted to participate. They were interested. They wanted to sort of know what was going to happen. They wanted to know what the LPC was going to do about this. And I believe the LPC has perhaps been sort of lobbying against these price rates, and so pharmacists are waiting to see what the outcome of what this lobbying activity is. And then finally we have some chain pharmacists in the borough who currently don't do the service, but who are interested in joining the service if the existing providers decide to drop out. So we do have provision to cover the borough if we have dropouts. So in terms of people being able to access needle exchange services, we're fairly confident that the coverage will be the same or similar. You know, there'll be some pharmacies who will drop out and others will take their place. And we also have to think about cross-border pharmacies because they can access over borders as well, where you're close to a bordering pharmacy or bordering borough. Kevin, do you have anything you'd like to add to that?
Yeah, just in closing, I think the discussions that we've been having over the past month, I think this matter was first raised to us by the committee, members of the committee. We offered to meet in person and we've sent a number of briefing documents to members of the committee. So it's been a really good sort of discussion for us to reflect on messages that are being received in the community, especially among pharmacists, and how we communicate better with those pharmacists about the proposed changes and how we can support them moving forward. So we're looking forward to the discussions this evening to see, both of all, to reassure you that these decisions were not taken lightly, but also to commit to ensuring that we continue those consultations with the pharmacists to ensure that we have good coverage in the borough, that we continue to track our outcomes, and that we ensure that as a result of this change, we are not observing any negative impacts as we move forward. And that's part of what we would do as part of our public health programming as well. So with that, I'm going to hand over to the chair for any questions.
Thank you, Chair. I think that the discussion that we had in your offices recently was very good, and we learned quite a lot from each other. But still, I was left a little bit uneasy by the comments made by Donna Timms about, as I mentioned to you earlier on, that she mentioned that no complaints at all had been received. And so that's why they took that decision that everybody was happy because no complaints had been received. In fact, that is not the procedure. That's the reason why they were not receiving any complaints, because the procedure is that they complain if it is an incident or a problem in the chemist. If it is really bad, they complain to the police and they inform CGL. If not, they just complain directly to CGL. And that's the procedure that they have. So it's not that they have not been complaining. They have been complaining, but with a different procedure. And in fact, they have records of incidents almost on a daily basis. And there are some people that they had been actually removed from coming back to the premises with orders from the police, because there are people that they had caused actually harm inside of the chemist. So therefore, they had been banned to come back. So that was one of the issues. The other issue was St. George's Chemist sent an email to Donna, and I think it was a misinterpretation. It's probably the way that sometimes we people, and including myself, when the English is not the first language, make a mistake and said something we didn't want to say. What he wanted to say is that he will be happy to also take the needle exchange, because he did not realize until late that the needle exchange was also part of the package. But he thought that by saying that, he will not be left out when the negotiations were concluded, because there was still 4 chemists, as you know, that they were not happy with the issues for a variety of reasons that we went through the other day. And so therefore that's where we are at the moment with the chemists. The only thing is, if St. George's Chemist is left out, the borough and my ward is the ward that is going to suffer, because there are no other chemists around. The only other chemists at the moment, and only at the moment until the 30th of July, are the chemists in the shopping centre at the Elephant and Castle, and that will be finished at the end of July. Boots was going to move into the Elephant Park, but is no longer going to move there. because of costs. So therefore, the only chemist will be the chemist in the Woolworth Road, and also chemists further along on the other side of Blackfriars. So that is the situation. That's where we are. So it's still in unease with the chemists, and I think I will be really very happy if you can talk to them and if you can explain the reasons why they understand, you know. But the thing is, they understand also that they are going through an awful lot of work on a daily basis. They're receiving an awful lot of aggro from clients, from customers. So therefore, they thought when they said we are going to be cut to half, my God, you know, it's a slap on the face. That's how they felt. And the reason why they felt that way is because of the way the communication that went along. It was not proper consultation, it was not proper communication, and that is the reason why they reacted in that fashion.
So thank you again for those comments, and again, we had a chance to discuss these in the briefings a couple of weeks ago in my office. So to the first point on the complaints, my understanding is, and Farah, you may want to chip in here, that you are right that they would complain to CGL. The process for us is that we would be receiving notifications of those complaints or problems through CGL, through the provider. And I think this feedback has just highlighted that perhaps there is a bit of breakdown in the communication channel there, because we would, as part of the contracting process, be expected to get that intelligence from CGL. So your feedback has enabled us to follow that up directly. To your second point on the method of communication, Farah had highlighted the fact that we went to the LPC first, and then we went subsequently with direct communication to pharmacies. The fact that a number of them have come back and we're happy to continue, happy to engage with the program, suggests that for the vast majority of pharmacists, they understood the communication and they're willing to be on board. This is not denying that things could be better. Things can always be better. And I think what we will commit to do following this, in fact, we started this, is to follow up with those pharmacies that are engaged and are not engaged, because we don't want to take for granted the fact that 10 of 14 have already said yes, because they may be saying yes unwillingly or with reservations. So we just want to ensure that we're working with those pharmacies. And for the 4 that have not yet come on board, we're happy to go back just to ensure that, to see if there's anything else that we can do, which may well include strengthening the complaints process so they know that we're engaging a bit better with them moving forward. So I think where we are is we're unlikely and unable to change a tariff because of the issues that I've mentioned before. But there's more that we can probably do to work with the providers to ensure that they feel more supported moving forward.
Giving them the moral support, I think it will be the most important thing you can do at the moment. Thank you.
So, thank you.
So I've just got a couple of questions. So we're reducing the amount that we pay on the medicated bit because we're paying twice as much as Lewisham and twice as much as Lambeth.
Twice as much as Lewisham and 40% more than Lambeth.
How did that happen in the first place?
So we got the tariffs, they came over from, the tariffs were the same that came over from the PCT at the time of the public health transition, and they haven't really been reviewed in the whole time we've been.
And why weren't they reviewed then?
I'm not sure, I just came into the job a few months ago.
Okay. Yeah.
So we tend to review contracts at the end of a commissioning period or end of the contracting period. I think this contract has been in place since 2017, you said? And so now it's coming up to the end of the contract. It's the right time for us to do benchmarking, to look at performance and quality. So this would be part of our commissioning process. I can't speak to what happened before 2017 because I wasn't here either, but what we're doing now is the due diligence that we would do with any contract coming up. And the benchmarking is a key part of our work to ensure that we're not overpaying for services. Final point in this, if Donna was here, she would say that actually Lewisham and Lambeth had already made changes to reduce their tariff over time. So it wasn't that they came in at that level, but they had gone through the process of looking at efficiencies as well. It's just that we are later in the cycle, and so we're doing this process now.
So, if you don't mind, we're changing the way in which we, for the needle exchange, the whole pattern of payment, how we do it. How do Lambeth and Lewisham do it? Do they use the system we currently use, or a different system, or the new one?
I think there are quite a few different systems around the legal exchange. It's quite a complicated landscape, and it's not very easily comparable across the piece. Some places pay using block payments, some use a combination of retainer and payment per item, and some are purely on tariff. So I'm not sure what the exact ones are for our neighbours, but we could see that the retainer was not working effectively.
I mean, I'd be curious to know what. It seems as we've had the experience with one end of this provision that we're paying 50%. Well, so they're paying twice as much as we are, 50%. You know what I mean? We're paying the most. Surely it would make sense to see what they do on the needle exchanges and make an informed decision on the basis of what their contracting processes are, instead of just coming to a system which sounds plausible and sounds better than what we've got now, but it may well not be the best system that we're using.
No, I think the drugs commissioning team have looked at the landscape, and it's as a result of doing both the benchmarking for price, but also the methodology that we came up with the option here. Donna Timms, who is the lead commissioner, isn't here this evening. She's not here today, but we'd be happy to provide the information.
That would be really good.
Yeah, no.
Can I just ask two other quick ones? In terms of the levels of usage, and I essentially may have gone through this with Maria, but the 4 pharmacies that have dropped out, are they pharmacies which essentially don't distribute, are they low users, and so therefore they're losing out by this system that isn't paying the retainer anymore, or are they people who've dropped out for completely random reasons? Who are these 4? I mean, I'm not so bothered about who they are, but it's the reasons why I'm just curious. Because the other reason, and this is my kind of final question, is there a list there? Okay, forgive me. Right, I can answer that question myself if I read the papers properly. And then the last question I would like to ask is there, or will there be at the end of this process, when you finish this commissioning, a map of cold spots? Because as Maria has identified, I don't think there is one at present, and clearly this is a service we wish, because it's a valuable service, to make sure there is as good a coverage as we possibly can do. And in order to facilitate that, is it worthwhile looking at whether different methods of payment make sense in different areas? So, for instance, I would not be opposed to paying a retainer to some pharmacies in an area where there is relatively low use to ensure that there is provision for that area of the borough, but indeed reducing it or eliminating it for areas where there's a number of pharmacies providing the service, or where there is high demand, and so the pharmacy can get a better price.
So at the briefing last week, there was actually a map of hotspots and cold spots into this part of the configuration, but also where alternative providers might want to step in those areas. So, for example, one particular pharmacy, there were 2 pharmacies that were close by each other, both providing the service, and one of them just decided to stop because they weren't getting any business because everyone was going to the other pharmacy. Now, the other pharmacy is now talking about withdrawing, so there's another one who's ready to go and pick up that business, and that's quite often the case in across the piece.
So, in the briefing that we had with colleagues a couple of weeks ago, we had the discussion on the importance of geographic equity of access and equity of uptake. I think Councillor Elisa, you mentioned that as being particularly important. And so we routinely will be looking at the hotspots and cool spots within the borough. We know that pharmacy distribution, we try to ensure that there is an equitable distribution of pharmacies in general, but at any given 3 to 5 year period, as we're commissioning, as the NHS commissions pharmacy services, we do have pharmacies that drop out of provision in the borough, and we work with NHS to ensure that that's corrected. So we're looking at this. We have the heat maps, we know where the gaps are, and we'll be working with our providers. I want to acknowledge Councillor Linforth Hall's point about St George's, because that might be the one that we are particularly concerned about, and again, we'd be happy to work with the pharmacy. We are less likely to want to have differential methodologies. It's much better to have a consistent methodology in terms of payment and to work with the providers on the best way of supporting them, rather than having differential models across the borough. But again, we're happy to work with individual providers to see how best to help them.
Councillor Knight?
Thank you, Chair, and thank you. Sorry for my lateness, but I was coming from work. I just want to, I think, make 2 points. One, I guess, is to pick up on the sort of process, I suppose, and the communication, because I do think that there are lessons to be learned in how we communicate with the pharmacists, because certainly my understanding sitting on the Health and Wellbeing Board is that, you know, we would like the pharmacists to do more and provide more services and for more of our residents to go to pharmacists rather than to their GPs. And I think if we want them to do that and we want to have that relationship with them, then I think we need to make sure that we have good communications with them and that they feel that not only they understand, because I mean, I saw a copy of the letter that went to the pharmacists, which was, I'm not sure there was any other further documentation, but it was just pretty much saying, do you wish to, you know, we're going to cut the rate in half, do you wish to sign up, please let us know, this is coming into force on the 1st of April. It was pretty business-like, not really any rationale that I could, you know, apart from the sort of the suggestion about the benchmarking, but there was no further detail, not that I saw. So I think the communication, I think, is definitely an issue. The other thing is I do want to just probe a bit on the benchmarking, because I mean, you say that you know, we're paying twice as much, but certainly the document that you provided us, that's only really sort of some of the story, isn't it? Because I mean, Southwark's paying £2 per supervision. Boroughs like Lambeth, they break it up depending on what type of drug and the type of thing, but I mean, that's 25 to 35% less. Lewisham is 50% less, but Greenwich were the same as. Bexley is actually 100% more than us. They're paying £4 per supervision. So, and yeah, Greenwich is the same, or yeah, pretty much the same. So it's not that we're completely outliers in regards to what we're paying, and obviously the reduction that this report talks about in the money that we have for drugs and alcohol being reduced by 40%. I mean, that's something that, to some extent, that we've had to, or we've done within our, that's a local decision in a sense. I mean, accepting the fact that our public health monies have been cut, but that 40% cut is not a sort of that's us managing our public health budgets and deciding where we make the cuts and where we can make savings and efficiencies, etc., etc. So yeah, so I suppose just because I think, as Councillor Limport said, I mean, this is not the easiest of services to provide, and there is a certain amount of difficulty sometimes for the chemists with the client base and in regards to their interactions, which can, I think, also sometimes impact on other people going in and out of the chemist. So yeah, if you just comment A on the benchmarking and B on the communication. Okay.
Yeah, so I think, well, for Lewisham, it is a neighbouring borough, and it is, you know, they have been, you know, paying £1 per dispense for quite a few years now. And so yes, I understand other areas are paying more, but we are required as officers to spend Southwark's money as if it is our own, and that means sort of benchmarking, getting the right price. You know, we you know, your colleague questioned why we're paying twice as much as Lewisham. You know, so you can cut it either way.
But there is variation.
There is variation, obviously. There is variation, but you know, it's, you know, we thought it would be. We thought it was. You know, it's not unreasonable to be paying the same amount as a neighbouring borough that's providing the same service.
But it's also good to acknowledge the role that the chemists are playing and the importance, I guess, of the service that they provide.
Yeah, absolutely. And I think you're correct. I think it is. I think you're correct in that perhaps the communication wasn't as gentle and collegiate as it could have been, and perhaps we probably should have. You know, there's learning there, I think, for the team.
Just my second. Oh, I think there's
Councillor Manning.
We've spoken a lot about benchmarking prices. What about benchmarking quality of the service? Was Lewisham twice, you know, as inefficient as us, or is Bexley twice as efficient as us? Because I'm worried about the quality of the service dropping because they're getting less money. They just basically shove the staff out of them and tell them to go off rather than spending a bit of time, make sure they're getting other services they need as well. You know, signposting into other services and that, as well as just giving them their stuff and saying to go along. Because if you've gone from £2 to £1, there's going to be pressure on staff to push them through. So I'm just worried about the quality of the service going down
As Kevin said, we will be monitoring the service really closely to make sure that we don't see any reductions in quality, and just making sure that we are that we are sort of receiving feedback and that it's working.
And just to say, a key part of this is looking at the feedback, the lines of communication and feedback, and the relationship with CGL, looking at complaints. I think it's something that we are committing to strengthening as a result of this discussion today. But I do take Councillor's point about quality, because it isn't just about benchmarking powers. I completely agree with you. It's about outcomes as well, and it's about quality as well. And so, very happy to reassure you that this is part of what we do as part of our commissioning. If there's anything that we can do to come back to you, just to let you know how this new methodology is working and what we're learning from pharmacists, we're always happy to do that. But I think as a matter of priority, we just want to ensure we're reaching out to those pharmacies and rebuilding some of those links.
I just want to, because I've got the heat map in front of me, I think I'm just going to continue my question that I asked for the conference call, saying that I'm concerned south of the borough, because I'm looking at there's 1, 2, 3, 4 wards, and there's probably only one needle exchange over 22 and 24. And I was saying that in the conference call, I'm really concerned about the coverage in the borough, because yes, we've got a lot in the north and the middle, but literally from when you go from Dockham East Dulwich downwards, there's probably only one or two needle exchange. And being that close to, I mean, I'm assuming that, is it because everybody does it at King's College Hospital, at Denmark Hill site? Is that the rationale, or is it community pharmacists aren't coming on board in terms to be part of your service?
I think there are three factors. One is historical patterns of access, so where drug users will go to receive their services. Second, where we have the high prevalence of drug users, and we know that they're concentrated, especially in the centre of the borough and to the north of the borough, and less so in the south. And also, thirdly, the distribution of community pharmacists who have agreed to participate in the programme. So what you're seeing are historical patterns which currently serve our existing cohort of drug users. We've always had that deficiency in the south of the borough, relative to the middle and the north of the borough. So we speak about equity of access. It doesn't mean everybody has equal access, but it means for those areas that need it most, they'll be able to have the access that they need, and we can continue to support historical patterns of use. I think as we begin to have the discussion with the chains, we can begin to think about how we look at geographic coverage, and on the call we spoke about taking away your concerns about the south of the borough to see if there's anything more that we can do. But far, I'm not sure if we've been able to do anything else on that since.
I think we're still in negotiation with various pharmacies and pharmacy chains around what the future might hold.
Members got any other questions?
Chair, thank you, Chair. I'd just like to second your concern about the southern provision. In addition to pharmacies, and there's no shortage of pharmacies in the south, we've also got the Tessagel Health Centre opening up in a couple of months' time. So I wondered whether you'd taken that into account in your processing. But obviously, if you're getting some of these national chains on board, they have chemists in the south as well. And it shouldn't cost us too much to have more pharmacies if they're only doing it on a per exchange basis. Is that right?
Any other questions? Final comments? Thank you.
Thank you very much.
Okay, on to item number 6, lane inspections, lane inspectors project. Is that Jeanette? Okay. And Ross as well, sorry. Before we go to the slides, if you just quickly introduce yourself, because let's not assume we know who you are. Thank you.
I'm Jeanette Laws, Director of Commissioning for Children and Adults with the Council.
Hi, I'm Ross Diamond. I'm Chief Executive of Age UK Leadership in Southwark.
So while the slides are being set up, I just want to take the report as read, and the slides that are being set up will give you an update about where we've got to in terms of the conversations between Age UK and the council in terms of the future of the service. So the first thing to say, and do chip in, Ross. The first thing to say is that the council and Age UK are very committed to making sure the service continues next year. We have really thought about what has happened over the last 6 months in terms of the service pausing, and how we can make sure that going forward there is a much stronger relationship in terms of how we plan for future visits. There is no intention to change the activity in terms of the service delivery for next year, so there will still be 6 homes that will be visited. More importantly, what we want to make sure is that the inspectors and the commissioning monitoring officers together are greater than the sum of their parts. So how do we get them to focus on their strengths? So in terms of moving forward, we want to think about how we coordinate visits so that the monitoring officers very much focus on the quality of the service in terms of contract compliance and compliance with CQC requirements, and that the lay inspectors who are able to have in-depth conversations with the residents are able to spend time speaking with residents and their families about their experiences. Thank you. Sorry. So I've been doing this off the top of my head. So in terms of the first slide, it confirms where we are at the moment. There are 12 volunteers and a coordinator was employed. That post is still vacant for 2 days a week. The lay inspectors visit about 3 times a year in terms of each home, 2 in the daytime, 1 at night time. And they produce reports that are submitted to Southwark Council, and that's the bit that hasn't worked as well in the last few months. And there has, as I say, been no recent active engagement between contract monitoring and lay inspectors. But we did have a meeting between our 2 teams last week where we started to explore what the service would look like from the 1st of April onwards. So in the meeting we've been exploring how we can establish closer relationships, think about how we complement the contract monitoring activities so that we don't duplicate. We've also been really keen to think about how the lay inspectors who are really strong at seeking the views of service users, and in particular service users who may not be necessarily funded by the council, can be supported to give us feedback about their experience of the service. One of the things that we've been talking about in terms of the potential future of the service is whether it could be expanded to include care at home. That's an area in terms of looking at some of the quality alerts and complaints that we have that we think we could do better. And we think the lay inspectors could add value to that in terms of, in particular, those who are receiving care at home who do not necessarily have family or friends to advocate on their behalf. So proactive seeking out their views apart from the service user satisfaction surveys that are undertaken throughout the year. So we want to be really confident that because we are bringing on board young inspectors as well, that there is parity in terms of the training and development that will relate to these 2 roles. And all of the conversations that we're having over the next few weeks will be with a view that we will be thinking about how we restart the service in April.
Thank you, Jeanette. Did you want to add something, Ross, before we go into questions?
Just to say that Age UK is absolutely committed to keeping this service going. We think it's a really valuable service. The funding was paused, not quite sure why. Last year we hadn't received the money, and so we the coordinator had left the organisation, so we had a gap, so we couldn't recruit till the money arrived. So when I started in post at the beginning of December, one of my first meetings was with Jeanette, and we said, what's the plan for this? The money had, I think, reached our account at some point in December. So we went to say, let's restart this. And Jeanette said, let's put it on the hold just for a short time while we can do the review, which is being talked about now, to consider improving the service. So we are now at that stage ready to continue this conversation, I suspect in part shaped by what you say this evening, but we will be meeting to develop the service and hopefully recruiting and starting up again. And we're very keen on the idea of expanding it to include people who are receiving care at home rather than informal care homes. And the key element about this is that it's providing a role. I met with the lay inspectors and one of them talked about it would be as if you were a family member, and it's that sense of having somebody who is an ally whose only purpose of going in is to think about how you would feel if you were living there or a loved one of yours was living there. So it's a very different role to a kind of CQC inspection, which has a whole other element to it, and that's the bit we really want to focus on and build on.
I've got a couple of questions. Any other members want to ask questions? David? Yeah.
Thank you very much for the presentation, and welcome to us. So 2 questions, I guess. One is, so it says in your letter to Councillor Olisso that under the previous arrangements you were inspecting 6 care homes in Southwark per year. Now, I can't say I can name all the care homes in Southwark, but I'm pretty sure we've got more than 6 in total, haven't we? So my question would be, what is there a reason why we're just doing 6, and will under the new contract will it extend to the other homes, or is there some rationale behind just doing some of the homes? And the second point is, so I mean the review you're talking about and the sort of trying to make sure there isn't duplication from what the lay inspectors are doing and what perhaps the council's contractors are doing, and also obviously what CQC are doing. It sounds very sensible to me. Did I imagine it, or were you, when you were saying that they should sort of focus on speaking to residents and family, etc., did you also say that they should focus on speaking to residents who didn't have any family, or did I? Oh, okay. All right. Yeah.
Okay, so the 6 are the homes that the council most used at the time at which the contract was let. And I think that's, I say contract, the grant was made, which was a number of years ago. So those homes have historically continued. And the homes that are visited are the 4 anchor homes, the Tower Bridge, although that hasn't been visited this year, and also the Elms. And that tells you that this is the choices, to your point, that were made historically and not necessarily where we want to be in terms of the placements we're making now and going to be making in the future, particularly with the commissioning that I'll be explaining later. So that's one of the reasons why we want to look at that and expand where possible. The care at home, as Councillor Alyssa rightly pointed out, we want to focus on the care at home because what we note is that the complaints we receive tend to be from family and friends on behalf of those receiving the service, and we're really grateful for those complaints. But the point is always made when we do our debriefs about those complaints. We like to meet with the family members and not just write to them. The point's often made and well received that that what's happened to those people who live at home, who do not necessarily have those connections, who may not be advocating on their behalf? How does the council assure itself? We say, because it is true, that we have satisfaction surveys that are sent out, but what we would like to be is more proactive. We know who those people are who don't necessarily have family and friends at home, and we'd like to do some regular contact with those individuals to say, how do you find the service? So that's something that we're thinking of expanding to. Now, whether that's part of this service or something else, it's something that we definitely want to do as part of our quality assurance, which is about seeking out feedback.
Thank you. So if I understand you correctly, you're saying that you'd like to extend it potentially into the home care, as in,
Yes.
yeah, people receiving. And are you envisaging? So I mean, would the new system perhaps take into account CQC reports of our homes and our boroughs to potentially prioritise which homes, if we can't go to them all, which ones we are going to, and also, what would it be? Just one visit a year that we could expect from from the lay inspectors, or is it potentially they would hopefully go more than once to each home?
So what we would like is to continue with the frequency that's currently taking place, which is 3 a year. So it's 2 in the daytime, 1 at night. And we think the nighttime visit in particular is a really, really important one. In terms of how we would prioritise the regularity of the the frequency of the visits by the lay inspectors. That wouldn't necessarily come increased frequency from them. What I would say is that, I think I explained at the last meeting, in terms of our risk-based approach for the contract monitoring officers, we increase the frequency of visits based on information like their CQC rating, based on the number of complaints or quality alerts we may have, or any other intelligence that we've received. So frequency of visits is informed by the information that you've described.
We think of the 3 visits effectively as one inspection, so it's a kind of they go together. Currently, it's the plan is if everything's going well, we would do one inspection, i.e. the 3 visits on each home per year. But where there is a need, but maybe something that the inspectors have seen themselves or other things, that we would absolutely expect to go back more than once during that year, just to check how things are progressing. And I think one of the successes of this programme to date is to see that the journey that these particular care homes have been on. I've spoken to some of the inspectors, some of the homes, particularly the Ankle ones, I think have really greatly improved as a result of the work. So it may be sensible that we begin to expand to talk to others as well. And that's something we would absolutely be happy to talk about.
Okay, I've got a number of questions. It's interesting you said you expanded to care at home. My question is, how many people are we talking about? Are we talking about 20, 30 people at home, or have we got that number? Because my second question will be talking about the 70% of people who have care out of the borough. How are we monitoring that? Is it just generic contract monitoring, or have we got other systems in place?
So there's in terms of the number of people we have receiving care at home, there's over 1,000, but not all of them are unbefriended, and that's where we would want the lay inspectors to focus on. That's what we're discussing at the moment, and it is very much in early discussions, but it's something that we're really keen to think about how we can do that. In terms of how we monitor placements out of borough, at the moment we do visit, in terms of contract monitoring officers, all our placements that are inside the London area, not just in the borough. Having said that, we'll be talking later on about the commissioning of nursing homes, because we recognise that over 50% of our placements, in fact about 70, are out of borough. And actually what we want to do is to bring those placements home. And that's why we're doing the tendering exercise that we have, and we have the council plan commitment to open 2 new homes in the borough, so that we have more local placements.
Any other questions, members? Councillor Merrill.
The care at home seems like a really good idea, but when you said 1,000 with 12 lay inspectors, I suddenly went, they've got to visit every day, somebody, you know. Is the resources there to do that?
So, 2 parts to the exploration of the care at home. First of all, we want to focus on those that are unbefriended. Of the 1,000, we don't think it's as many as even 50% that are unbefriended. So we need to be really clear about that. We're not intending that we would visit the family, the service users, and that's really important to say. What we would want to do is to have a telephone conversation with them. And that's partly because some of the people who are at home may, for example, be relying on key safes for access to them. That would not be appropriate for lay inspectors or indeed contract monitoring officers to have access to that. So we would be expecting it to be a telephone conversation. And it would be something that was very much planned, as we did when we did the mobilisation, with contacts ahead of time, saying you should expect a call, this is the person you'll expect. So it's going to take a lot of planning, but I think it's a really important enhancement in terms of how we help people to be able to feed back on the services they receive.
Yeah. I'm assuming from a telephone conversation, you will have very well trained lay inspectors, because a telephone conversation is very hard to see. Sometimes you see things you can't hear. So, and then what is the process then if they are concerned from a telephone conversation? Is there a visit, follow-up visit? What's the process then?
Okay, so we're moving into a lot of detail that has not been scoped out yet, but what I would say very clearly is that we would expect, as we would actually in terms of a lay inspector going into a home, that there will be training about safeguarding, knowing how to raise those issues. It's not intended that the lay inspector holds these issues. The idea is that they are seeking someone's voice, to be able to then be able to relay that back to the council. So it will be very much a joint piece of work, but what we would want is someone to feel that they are speaking to another member of the community rather than a council officer, and that's really what we want to encourage.
Go on, Ross.
Thank you. Just to respond, the aim would be to have 12 lane inspectors. They will be volunteers. They will be very well trained. We've started to talk potentially about sharing some of the training that your new young inspectors will have, but they will get training as the previous lane inspectors have around a range of issues. If we do the care at home calls, that will be an additional set of training. Some of the lane inspectors that do the visits may decide they don't want to do the phone calls. Others may want to do the phone calls but not the visits. But we're very early discussions around this at the moment. Our first point is that we want to get the lane inspection service going again, but very happy to talk about this new care at home phone calls. And one of the key benefits of the lane inspectors is they're there purely on behalf of the people they're speaking to. So not only will they feed back the information, if there is concerns at the phone calls, they would, we as Age UK would be wanting to see some action from it, not just reporting into a void. So we would be pushing to hope that solutions were found if problems were uncovered.
I think I just want to follow up from Councillor Merrill's thing. My concern was, it's like, I don't want you to create a rock for your back. And do you know what I mean? Because if you're going to do, say, 10%, that's still 100 people you'd have to call. And there's bound to be, all you need is one or two concerns from those phone calls, either from the provider or the floating care support they're getting from a list of providers and whatever, for you to create a lot of work. So I think, has that been scoped in? Because obviously in terms of resources, you're taking it to a different place, but then also I'm not even thinking about the 70% of provision that's out of borough already. Do you see what I'm saying? I mean, the project can go from that to, and is it about looking at your capacity and maybe using some existing staff? Because I think we expect a lot of volunteers, but is it worth maybe revising the project to say maybe we need a full-time worker or some paid worker, because you're expecting the volunteers to do a lot, which is very experienced at that level. So why do we actually pay people for doing that valuable work?
So that's why we're scoping the work out to understand what the cost would be. We're not expecting Age UK to do it within the current cost envelope. So that's probably the first thing I should have said. But in looking at the redesign, we are looking for a redesign that is has a fair price attached to it. But what we're saying is we recognise the strengths of what the lane inspectors bring in terms of care homes, and we want to expand it to an area which is, the biggest number of service users that we have is in our care at home. Most of our residents, in fact all of our residents that receive care at home are in the borough. This is a very different place, so it's not and again, if we uncover things, then in some ways I would say that's a good thing. That's what we want to do. We want to uncover things and be able to address them, hopefully early on, or definitely to resolve them. We want to seek out feedback so that we can help providers to improve and to keep people safe. And we do feel that this is an area, home care, which is really important because people do want to stay at home where possible, and people do need to move into residential care, but a smaller number of cohort of people that we support through the council.
To say something.
Only to say we'd be really delighted if the council would like to give us more funding and we can employ more staff to support more volunteers to do more work. We'd be delighted.
Councillor Hartley, and then.
Thank you, Chair. Without referring to them specifically, that sounds like some of the wish lists or the magic wand options on some of the reports in our private agenda. I think in those reports it comes through quite clearly the attitude that the lay inspectors are taking. It seems really admirable that process should go on and be adapted. I share some of my colleagues' scepticism about the scale of what might be required for care at home. We all look forward to the day when we've got the resources to deal with this issue properly. Can I just ask, in terms of the appointment of a new coordinator, is that something that's ongoing, or is it a relatively simple process that you anticipate taking forward quickly?
Yeah, we haven't had conversations at all yet about the care at home work and the expansion. We've been asked to submit a budget based on what we think was based on the care home visits, which we've done, and then so the discussion is really very fresh, so we haven't got very far with it, but it would be a pretty quick process to recruit a new coordinator. At the moment, we're thinking 2 days a week. Depending on the scoping discussion, that may change. But yeah, we'd be able to get going again pretty quickly. I think we need to start retraining and training a new cohort of lay inspectors, but there are lay inspectors currently up to speed, so we could hopefully be able to get started again very quickly.
Joan, did you want to come up to the microphone? If you just introduce yourself to the commission. Yeah, press the one on the right hand side.
Yeah. Hi everyone, I'm Joan Thomas and I am the old coordinator of the Lay Inspection Project and I retired in August. First of all, I'd like to say how delighted I am to hear that the Lay Inspection Project is going to continue, because I was very, very concerned when I heard it wasn't going to continue. So first of all, I want to say that. I also want to say I'm also delighted to hear that there's going to be something similar for care at home as well. I think that's very, very necessary because, you know, in a care home, people are wandering around. You can see what happens in terms of home care. It's behind closed doors. So I think that's very, very, very necessary in terms of having that voice, having even if it's a telephone conversation, having a voice rather than the usual annual survey, which doesn't usually get completed anyway. But I would also say in terms of that before I did the Lay Inspection Project, I was at Age UK doing the home care quality check. So I was doing something for home care. Please use the resources from that and what we learned from that as well. But that is, I really don't see that in the scope of this new coordinator doing 2 days a week. It's just too much to do. Okay, what I just wanted to ask then, oh yeah, before my question, I also wanted to say I'm also delighted to hear that there's going to be better communication between contract monitoring and the lay inspectors. You know, there's been a change of personnel in the council and the communication stopped because the Lay Inspection Project no longer had input from the contract monitoring team, which they had previously. That is so important for the lay inspectors to say, look, we couldn't look at that, could you look at it? Then for the contract monitoring team to say, yes, we have, this is the response, we haven't got time to look at this, could you ask about that? So that is just so important. And I would say also, if there's any change in staff, that both parties let each other know. I spent months trying to find out who to send inspection reports to. It was because I bumped into someone here at Tooley Street, the contract monitoring officer who used to come to the lay inspection meetings, that I found out why there had been no presence at our lay inspection meetings for 2019, because I bumped into that person, that's all. So that communication is very, very important. So I'm really happy to see all these things. I have a question now, though. I was looking over Esme's shoulder there at the letter, I think, from Ross to you, Councillor Elisa, around the discussions to change the format of the visits and reports to ensure they complement each other rather than duplicating any work from the Council or CQC. Again, I'm delighted to hear that the service, you know, how it's done is going to be reviewed. What I'd like to ask, though, is how is that going to be done, and will that be reviewed? What my concern is, things will be removed from the existing format. In terms of the existing format, that has been built up over 3 years, and the additions that have been added have come solely from family members. Let me give you an example. For example, continence care would be included in the personal care bit, but because family members were talking to us specifically about continence care, we created a separate section. You know, the inspection template as it stands now is probably about version 9 or 10, because over time it's the family members who've actually mentioned things to us that we haven't considered before. So I'm just concerned about things, you know, being taken off that, because and you know, in a few months' time, will the current group or the future group of lay inspectors have a chance to comment on that? Because I think it's very important that you ask the opinion of those who carried out the lay inspections, what they think should be included. The previous focus was very much on speaking to family members in particular, and this was something that the contract monitoring officer and we discussed a lot, in terms of like, what she was doing was looking at files, looking at PIs and stuff like that. What we were doing was sitting, observing, talking to family members, going to family meetings, which are sometimes in the evening, sometimes on Saturdays. But that has been the focus the whole time. Also, just to say that I was a family member of someone who was living in a care home, and although I wasn't involved in inspecting that particular care home, I feel very much that I understood what family members were going through, and family members are so overwhelmed by everything. They just want to, you know, speak to someone who's not from the care home. And also not from the council, because actually not everybody in the care home is linked to the council. You know, there's a lot of self-funders who've got no connection whatsoever with the council. Just about, you know, how those changes are going to be reviewed, and that I'm delighted, absolutely delighted to hear the project will continue.
Thank you, Joan. Did you want to pick up any of those?
So I think that we're not suggesting that we're going to limit the conversations that I had, and I think continence care is a really good example of something that the council would want to know, so that we can share with our health partners, because continence care is funded through the funded nursing care element of the service, which the CCG funds. So we'd want to share that information and look at the person's whole experience, rather than looking at our contract compliance, and that's why we talk about the complementing of what people are doing. So we don't want to stifle the conversations or say it has to be led by this down this particular route, but what we are saying is we want it to be informed very much by conversations, rather than feeling that people need to check things, because that's what I think a contract monitoring officer should be doing. In terms of the what people think, I absolutely agree we should be reviewing this. And I'm really delighted that we have now established a good relationship in terms of our two key officers who have met and will continue to meet. And I would expect that, similar to the process I'm going to describe about the co-design for our procurement of nursing homes, I would expect that we do involve people in terms of what it looks like in terms of going forward. Now, I'm really conscious that I don't want us to pause for any longer than we need to. So in terms of the care home lay inspections, I think we should just get on and do those, and we are agreeing the funding for that. But the care at home is something that I definitely want us to see us evolve into, for all the reasons I've said before, and that Joan has helpfully reiterated.
Thank you, Joan. Yeah, but also I think it's, thank you for that contribution, Joan, but also I think it's important in our conversation I've said that for me the lay inspection is the one place that we actually hear the family voices, you know, and it's not CQC, it's not that, and they can actually be honest with someone and say this is what's working, what isn't, and all you need is one family who's not happy for us to do that learning. That learning can continue 5-10 years, because I want that learning to be fed into our future proofing of our 2 new nursing stroke care homes that we're providing in the borough. I don't want us to make the mistakes that probably some providers may have been doing 5-10 years ago. We knew about it, and we're not actually future-proofing that out, because the family voices are really important you know, we shouldn't have to wait for a safeguard load or whatever. If the lay inspection, I know it's only £10,000, but the fact that that's the only source of we hear from service users, families, it's really important that we retain that and actually amplify that and say, how can we, you know, use that in our service delivery going ahead, because that shows that we've learned from any lessons. So thank you for your contribution, Joan, and thank you, Jeanette and Ross. So Jeanette, did you want it? For the, yeah, okay, I think that's quite straightforward, thank you.
Sorry, I should have moved that to keep it on screen. So you also asked at the last meeting that I explain where we are with the commissioning of care homes, and I thought it might be helpful to give you an insight into the role of residents in terms of the procurement, in terms of the evaluation for our new nursing homes. So if I can again take the report as read and look to the slides related to nursing homes. So let me just say first and foremost that at the moment the council is making placements predominantly in Tower Bridge, and we are also in discussions having access to a second care home in the borough on a formal basis, and that is Queen's Oak. No, Queen's Oak is on the border with Lambeth. Queen's Road, yeah. Now, we recognise, and I think I said this in the earlier presentation, that the majority of our nursing home placements are out of borough, and we talk about this in the gateway reports that we've presented to Cabinet. And we don't feel that we should continue on that basis. And we also recognise that the quality of care locally could be much improved. So both of the homes at the moment are rated as requires improvement. So in terms of moving forward, in terms of having high quality local nursing beds in the borough, we have two really helpful ways forward. First of all, we have a council plan commitment that says that we want 2 new nursing homes in the borough. So that's really about buildings, but more importantly, what we want is a high quality care in those homes. So we are currently going through a tender exercise where we have invited organisations to bid to either formalise arrangements we already have, or to open 2 new homes, or open a new nursing home. So at the moment we are speaking with 3 providers in the borough, and we are working through both the quality of care that they'll be delivering and the price. Now, in terms of evaluating the quality, we have had quite an extensive process. So we have visited the providers who may not have a home in the borough by going to visit those care homes. But we have also established a co-design group, which is made up of a number of members of the community. So the core group is coordinated through our engagement and consultation staff members from both the council and the CCG. It has also involved Health Watch and Age UK, and has been led by a commissioning manager in my team that is jointly funded by the council and the CCG. So in terms of early engagement, the council had a targeted audience in terms of meeting with a number of people to develop what we've called I statements. And that was through a series of workshops that combined the voluntary sector as well as residents and families of care homes. But then we also went on to develop, then do some further engagement where we met with over 100 people throughout the community in either extra care shelter schemes, in care homes themselves, and also with particular groups like the Southwark Pensioners group. So we met with a number of people to try and understand what was important to them in terms of care. And some of those people that engaged also happened to be lay inspectors as well. From those residents that we met with, they identified a number of themes that they felt were really important for good nursing care and how they would want that delivered to them. So what we wanted to do was to have them more involved in terms of evaluating whether the providers we were speaking with were meeting their expectations. So we asked a number of people if they were prepared to volunteer to actually meet with the potential providers, and we had 14 volunteers in relation to the co-design group. The group were met with on a couple of occasions before meeting with providers in order to be able to prepare them in terms of thinking about the questions that they may want to ask in terms of the providers they met with, and really thinking about their approach in terms of evaluating the care that would be delivered. Of the 14 volunteers, I believe 3 dropped out during the process, and it may be because they it could be for various reasons, but we did wonder if perhaps they needed more support in terms of engaging with providers. Perhaps they felt this was more formal than they had expected. But we did have 11 people who did meet with the 3 potential providers, who worked through the themes that they had identified in terms of what they expected from care. And those providers, the outcome of those discussions are now being brought together by the group that I mentioned at the beginning. The Health Watch, Age UK, the commissioning manager and the consultation groups are bringing all of the information from those meetings together so that there will be one further moderation meeting to feed back our understanding of their feedback to the co-design group, so that that will inform the final discussions that the negotiation team, which is led by me, will be informing the discussions we have with those providers. And that will lock down the care that we will expect in those care homes as they are built and the care is delivered.
So my first question is, have you made the decision, have you got to the point where you've made the decision about which provider, and if not, when is that going to happen?
So the decisions will be over a period of time, but the first decision is not likely to be before May, and that's because we first of all need to have the moderation meeting, which has not taken place in terms of having the co-design group feedback. Once we have that information, that will help us in the final discussions with the provider about the finalising the terms and conditions in terms of the specification, and also inform the price that we would be agreeing with the provider.
Any other questions, members? David?
So, is it a requirement of the contract that 2 new homes will be built, or is it possible that they could use an existing building, or even an existing home, and that they could become the new provider, or will there definitely be 2 new homes, brand new homes?
So the intention is that there will definitely be 2 new homes over time. And 2 of the providers we are talking to are talking about building new homes. One provider is talking about using an existing building. We are, whilst we are committed to having 2 new homes in the borough, that's not to say that we wouldn't necessarily want more homes, beds in the borough, which may be from an existing building. So we are having a variety of conversations with providers. Our overall aspiration through the tender is that we have more local high quality beds, but we have a council plan commitment which we are working on with providers in terms of building new homes as well. So they kind of overlap as a Venn diagram, if that makes sense. So 2 are definitely offering to build new homes, if that's helpful.
So, Councillor Maria Linford's fault. I've got this cough. So thank you for that clarification. So, obviously, out of our control, though, obviously other homes could close or open in the borough. So would that have any effect on our commitment to build 2 new homes over this period of, I'm not sure there's a period of time when this is going to be delivered, but and I mean, obviously there are obviously, I think you said 70% of people are in care homes outside the borough, but obviously in quite a lot of cases, I presume that will be the choice of relatives who've chosen to perhaps move people outside the borough so they can be closer to them. So our aspiration is presumably not to get 100% of people back into Southwark. It's to get those who maybe have been moved out where there isn't a relative or something, to get them back into Southwark because there wasn't enough provision or something. Is that correct?
So that's absolutely correct. We've calculated that about 80% of those that we placed out of borough would have preferred to be in borough. And that's been through about 80% of those placed out of borough. And we've done that based on the social workers looking at the cases of those who are out of borough. You're absolutely right, there are, for some reasons, you know, family members have moved away, that they would prefer their loved one to move closer to them rather than necessarily stay in the borough. But the majority of people are out of borough, tend to be in neighbouring boroughs, but we would like them to be in the borough, being able to access local services like our enhanced GP service that we have in our care homes here, and able to access, for example, our mental health service that we have for dementia in terms of SLAM. So we are keen for people to be local where they would like to be, and we think it's about 80% of those placements.
Just on the homes opening and closing and whether that has any impact on our commitments.
So there is always a potential that a home may close. We, in terms of our conversations with the providers we are working with, and in terms of the marketing engagement we're doing at the moment, we have no sense that there's any intentions for homes to close. I recognise that we did, when I arrived, have a home close. I'm going to be open and say...
You weren't connected with them.
What I'm going to say is it was a home that had struggled with quality for a number of years. And so when we go back to the definition of wanting high quality local beds, I'm going to say that I didn't lose sleep over that fact, apart from the disruption to those residents. But in terms of receiving quality care, that home had struggled for a long time. And I think that what we should be doing is investing in homes that will deliver high quality care in a sustained way. And that's something that I think is really important.
Any other questions on this? Thank you, Jeanette. Thank you. Members look to point item number 8, review of mental health of children and young people. Pages 21, I think that's the London Assembly report connecting the ACEs, so domestic abuse, parental mental health and parental substance abuse. Any comments? Any members? The only comment from me is that I just wanted to see how we as a borough, what we're going to do in terms of feeding into this trauma-informed approach. Because in terms of what our cabinet members doing in terms of health under the mental health brief, but also is that linking into the other departments that we've got for even public safety, because that would cover the whole violence and domestic abuse area as well.
So, Chair, I agree with you that that's a really interesting viewpoint. I think from reading this report, the trauma-informed approach, you know, if you're trying to put it into a layman's approach, sounds like be understanding, doesn't it? It sounds like deal with people with a bit of understanding for their circumstances. And the question is whether all of our systems actually match up to that. So I think that would be a good challenge for Southwark systems.
Maybe we need to put that challenge to some cabinet members to say, how do we use this trauma-informed approach across the piece? Because obviously if they're doing it in, they have tested it in 2 or 3 boroughs, Islington or whatever, and it works. It's about that coordination of the agencies coming together and doing it properly. If there's no comments, if we can go on to the work programme, but Julie's not here. She could be back. The work programme on page 32 to 39. I think that's quite straightforward. Do you want to go through?
Yeah, so
We're just talking. We just had general comments on the ACE report, and I was suggesting that maybe we need to put the challenge out to cabinet members about how do we actually use that trauma-informed approach in Southwark, because it cuts across community, public health and community safety. It cuts across 2 portfolios, but how do we actually drill it down to the borough-wide approach? How are we actually going to do that? Because it's good having a report like that, but what does it mean for us for Southwark, and how we're actually going to do it?
Yeah, I think, I mean, one of the, when we had the first scoping reports, Partnership Southwark came along and they identified that, in their work, they were using, ACE, the issue of ACE to frame some of their, future work. So that could be an approach to get an update on that. But of course, yeah, I think you're right, the Cabinet members work as well on the mental health. That could be another approach to ask some more questions about that. So in terms of
Are they taking this approach?
are they taking that approach? That could be something worth pursuing.
Because the reason why I say that, because I don't want the mental health work that we're doing to be done in isolation. It has to link into what else is happening within the borough walls or what's happening across London as well.
Yeah. So we could get some. Is there any further action you wanted on that? Or? We could just make a note of the links
make note of the links, but maybe as a cabinet member, have they thought about that and scoping in their work for the mental health approach? Because I know that nearly £2 million has been spent in the mental health, so it'd be good to see if that links into this.
Yeah.
If we talk about the work programme, is there any comments, suggestions for everybody in terms of pages 32 and 33 of our work plan? Because at the moment I think it's just drafting the briefings.
It could be good to come back to the work programme after you've taken the closed report.
Right,
because
okay.
You might get some
Something
sort of
from
lines
there.
of inquiry.
Okay.
Yeah.
Okay. Let's go back to...
So you're probably at the end of the open section now. So we could move into the closed session.
Right. So this end of open session, we're going to close off.
Yeah, and then get